dietitian. Just, this is the last slide. You see, we are always dependent on the data from other countries. Friedman Jangs from United States. The other study from the Norway, the lab study from Nigeria, Uganda, from the China, from the Japan. Do we have any study from the India? We don't have one or two studies which are not published in a Code Impact journal. On what things we have to rely? This is the problem, because our patients are much smaller in size. Our Asian Indian population is much smaller in height. They have obesity, central obesity, not many other factors which are present, which are not present in the other ethnicity. And we are relying on the data of the Caucasian population. No, we should not be. We have a lack of research studies. So to conclude, I can say, designate label stage carefully, avoid unnecessary intervention before active phase, update the labor room staff, resident, pediatrician with the latest advancement in the labor room protocols, evaluate your outcomes regularly. This is very important. Careful planning and management can decrease the primary cesarean section rate, individualize the patient management. So this finishes with these are few of my video lectures demonstration, which I have done with the demonstration also on surgical instruments, mechanism of labor, clinical cases, might be helpful for all the PGs and the undergraduates. You can go to my site. This will be active soon. It was on the other platform, but by Monday, this will be available on this platform. Thank you for patient hearing.
Thank you, Dr. Aruna. I think it was an excellent presentation, I should say. And especially when you told you should call it not the Zhang partogram, but rather the contemporary partograph is what you should be telling. And also about you gave a beautiful explanation of the chart and of the Zhang, how you explained it was very nice. And another important thing, especially for our postgraduates, is that whenever labor is not going as planned, like you said, there's arrest or there is a failure of descent, things like that, or failure of cervical dilatation, you very nicely highlighted that the things we have to reassess the patient. Is there something wrong with the fetus? CTG, look at the CTG, look at the position. Is the head going deflex, especially in the later stages of labor, towards the end of the first and second stages, correct? And how about the maternal pelvis? Have you made a wrong assessment of the pelvis? So these are the various, and of course the maternal condition overall. So beautifully you highlighted it. That was very, very important, I think, especially for our postgraduates. Of course, the consultants will know what we are talking about, but this focus, I think, was very important that you did on the other factors that we have to take in. And another important thing, like we are saying, 6 is the new 4. So WHO has told that you take 5 centimeters, and we are saying the Zhang, etc., says 6 centimeters. And of course, that is to reduce unnecessary, and they say non-evidence-based interventions which we so commonly do. So, and we are trying to interfere in a normal physiologic process. So that also was very beautifully highlighted by you. And another very beautiful highlight by you was that about the Indian population, all this data we are getting from abroad, whereas our Indian population, their physiology, the physique is different, how we respond is different. So I think that was, the best point at the end of the talk. So I think it's a wonderful presentation. I think there are a few questions for you. So does this, Dr. Ravikant is asking, does the 6 centimeter rule apply in high-risk pregnancy or preterm pregnancy? What is your answer for that?
It applies everywhere. You cannot separate, but again, now you have to evaluate the high-risk factor also simultaneously. Supposing our BP is shooting up and you are saying, I am sitting on a 6 centimeter according to Zhang, right? So the treatment should be individualized. Guidelines are to guide you, not to guard you. Guidelines are there, but each and every guideline has to be modified according to the patient's benefit, what outcome we are giving. See, our aim is to decrease the cesarean section, no doubt. But that cesarean section will always be reduced by doing Preventing in a primary cases, in a low risk cases, you can always reduce. You see, most of the institutes are nowadays are having a cesarean section of 30 to 40%, I can assure you. But what should be the cesarean section rate? It should be between 10 to 20% in a high risk. And everybody says we are sitting at a tertiary care center and we are dealing with a very high risk cases and we are having 1,000 deliveries. How can you say that the 1,000 deliveries are all are high risk? No, they are not high risk. Out of this, only 200 are high risk. Rest of them are the low risk cases. Why can't we deliver them vaginally? This is the point I want to convey.
Thank you, Dr. Now, one more question from Dr. Sanjana Kumar. Should we cut down the questions and ask at the end of the session, if there is time?
Ma'am, you can take now only, ma'am.
Yeah, okay. One more question.
2 or 3 questions you can take, ma'am.
More, I think PGs and staff want to get all their queries cleared. One more from Sanjana Kumar is similar to this question. What do you say about using partographs for very small babies, preterm labor, breech deliveries? Do you think special partographs should be designed?
Again, you do the study, but still the whatever partograph we are available, we are having a WHO partograph and a Jhang's partograph. You see, you take that table and you can breech delivery, very difficult. These partograms should not be used for abnormal presentations. Then it's okay for malpositions, but for malpresentation, don't use them.
Yes.
Right?
Yeah, agree, completely agree with that. One more question from Dr. Dikshita. Your opinion regarding increase in meconium stain when there is protracted latent phase?
See, that's the problem, whether it was a protracted latent phase or not. There's no word like protracted latent phase. First thing, it is always a prolonged latent phase, number one. Second thing, decide whether she has entered into the latent phase or not, and what intervention you have done during this latent phase, because we have a tendency to induce the patient when the patient comes to us, very poor bishops. Are yaar dalo, just give her Cervi-Gel and induce her. She will be there occupying our labor room bed. So it is very important to decide which phase you are dealing with and how. Unnecessary intervention should not be there. There will be no meconium staining, right? It is meconium staining only because of your interventions.
Last one question we'll take, I think. Dr. Mrudula is asking, ma'am, what is the abnormality named if there is unripe cervix even after 3 doses of Cerviprime?
Yeah, but I have covered this. You see, 3 Cervi-Gels, that doesn't mean failed induction. You have to give oxytocin for 24 hours along with amniotomy. Without amniotomy, you cannot label this patient as a failed inductions. So if whenever possible, do the amniotomy, give 24-hour oxytocin. I know your heart rate will go to 120 when you give oxytocin for 24 hours. So you can modify your practice. You see, you can give it for 12 to 16 hours when it has been said that 15 hours in a multiparous females and 12 hours in a nulliparous female is a good time to observe after amniotomy. So amniotomy, remember that active phase amniotomy, failed induction amniotomy. This is a one thing very important you need to take as a take-home message.
Thank you, Dr. Aruna. I think we have the next speaker.
I would like to, yes, ma'am. I would like to take 1 minute to thank Dr. Aruna, ma'am. So this COVID pandemic, it came as a blessing in disguise to have you as a speaker, ma'am. Thank you very much.
Thank you, Bhavya. Bhavya is our old colleague. I really appreciate that you have remembered me. Thank you. I am enjoying.
Thank you, ma'am. Over to you, ma'am. Vatsala Kamath, ma'am.
Yeah. So now the next talk is Pitfalls in Second Stage of Labor by Dr. Lata Venkatraman. She is FRCOG UK and MRCPI Dublin. Dr. Lata Venkatraman, I think this is of the previous speaker.
Yeah. Thank you very much.
No, I think they are not put your slide yet.
Yeah, just a minute, ma'am. I welcome you, ma'am.
Yeah.
Okay.
Thank
Now,
you.
Dr. Lata Venkatraman, she's a lead consultant at Rangadore Hospital, Bangalore. She's also the president of Bangalore RCOG Trust. She's a faculty and research guide at SVYASA. She is the past president of Bangalore Obstetrics and Gynecological Society. She is the national expert on diabetes and pregnancy and trustee, that's a trustee Doctors for Seva. She is the joint secretary, Karnataka Medical Education Trust. She's a coordinator of Part 1, Part 2, MRCOG examinations, Bangalore. I think our PGs will be interested in this. And she's a consultant and advisor to NGOs, Doctors for Seva trustee, SVYM Sargur. She's a medical advisor to biomedical engineering companies like Blue Crimson and Genetic. She has been awarded CNN India Positive Award. Over to Dr. Lata Venkatraman.
Thank you very much. Thank you very much, Dr. Vatsala, for that introduction, and thank you, Dr. Geeta Doppa and team for organizing such a wonderful conference. Let me start sharing the screen. Can you all see the screen? Yeah, see the slides, please?
Ma'am. Yes, ma'am.
Yeah?
Yes, ma'am.
Okay. Am I audible? Okay.
Yes,
Yes,
ma'am.
you
You're
are.
audible, ma'am.
Right. Thank you very much. Yeah. So pitfalls in second stage of labor. A wonderful topic. Second stage of labor is the climax of birth. By the delivering woman, her partner and the care provider, and to achieve the end result, that is a safe mother and a safe baby. So we will have to define what is second stage and what is a pitfall. So second stage of labor is defined as duration from fully dilated cervix until delivery of the baby. So there are two phases of second stage, more and more recognized as two phases: passive phase, passive descent of the fetal head; active phase, also known as expulsive phase or bearing down or pushing, that is the maternal effort. What is a pitfall? It is a hidden or unsuspected danger or difficulty or drawback. So there can be many problems during the second stage of labor, and second stage reflects the period of maximum stress both for the mother and the fetus, and of course the obstetrician. So maximum dilemmas in decision making for obstetrician also. The balance is tough. To achieve an optimal result, both for the mother and the baby, it is the obstetrician who has to walk this tightrope walk. So on one side, there is challenge to reduce rates of emergency sections, which are associated with increased maternal and perinatal morbidity and mortalities, and also, on the other hand, to avoid adverse maternal and neonatal outcomes by giving vaginal delivery. So the balance is truly tough. Well, so to talk about the pitfall, I think it's very, very important to talk about the main pitfall. That is, women have to labor to reach the second stage. But unfortunately, many women are not entering into labor at all. So where's the question of reaching second stage of labor? The biggest pitfall that we are facing today is not allowing labors to progress to the fullest potential to achieve a vaginal delivery. So if this is the pitfall, is there any point talking about the pitfall of second stage? Because obviously the laboring woman will have to reach the second stage of labor for me to talk about pitfall. And the whole labor congress becomes questionable if we are not promoting vaginal deliveries. I think our primary aim is at least to reduce the primary cesarean sections, which will have a long way to go for the mother and also for the progeny. WHO statement, cesarean sections should only be performed when medically necessary. And also it publishes a statement on the rates of cesarean section and proposes to use Robson classification. Ideal rate, still it holds on to 10 to 15%, and also says above 10%, there is no evidence that mortality rates improve either for the mother nor for the baby. So, are we all geared up for giving vaginal birth? Then only there is a meaning, as I repeatedly say, for pitfalls in second stage. As we all know, Dr. Srimati has already shown you these slides, 4 times more maternal mortality with cesarean sections, and also alarmingly high placental abnormalities, including abruption, 30% placenta previa, 30 to 100% in subsequent pregnancies. More the number of sections, more the incidence of placenta previa and adherent placentation, and dense adhesions in the abdomen, which can lead to visceral injury, etc., could be found in nearly 25% of second cesareans. And mind you, you are going to affect the quality of her obstetric career. 17% more likely to have a miscarriage if they have had even one cesarean section, and 27% more likely to experience a stillbirth with a previous cesarean section. So are we not harming our women and also jeopardizing their obstetric career by doing unnecessary cesarean sections? Medically warranted, yes, but if they are not fitting into Robson criteria, truly, then are we justified in doing cesarean sections? So, and also look at the effect on the progeny. The gut microbiomes, see, just a foot of the pelvis, that is the birth canal, why does the baby travel for so long? Because there are a lot of fetal programming that happens when the baby is traversing through the pelvis. The gut microbiomes, which forms 80% of anybody's immunity, is mainly formed as the baby is traversing through the pelvis. So if we jeopardize this baby to be traversing or traveling through the pelvis, how sad. So you get a lot of obese progeny, and also progeny who have a lot of immunological problems. So are we right? Are we not affecting the quality of the mother and the progeny by doing unnecessary cesarean sections? Why am I talking about this? Because I want you to be convinced that vaginal birth is better for the woman and the progeny, okay? Because if I talked about the pitfalls, you will start wondering, oh my God, why should I put the lady through this and get into much more muddle myself, and also probably more of medical legal issues? No, it is actually the benefits of vaginal delivery overweigh all the risks. Okay, what are the pitfalls in second stage then? Too short or prolonged second stage, because the very definition of duration of second stage is actually, debatable. Instrumental deliveries and problems, second stage cesarean sections and difficulties, interpretation of CTG decisions and dilemmas. So these are the pitfalls that I'm going to touch upon in this lecture. So duration, it is difficult to correctly diagnose. It is like diagnosing latent phase of labor, okay, which happens over days to few weeks in women. Similarly, during labor, when she is fully dilated, unless she has bearing down sensation, you might not be able to recognize. So if she is fully dilated, just put her up on the stirrup, ask her to push and get on with it, and just deliver her is not the same. It could be too short a second stage with increased instrumental and cesarean section rates. It is often iatrogenic, these instrumental deliveries and sections in second stage, because of the hurry of the obstetrician rather than a medical reason. Controversy regarding duration and definition of prolonged second stage persists. We will come to it a bit later. Changing definitions for second stage duration itself is a big problem. So up to 2012, people said up to 2 hours in Nalip. In many studies, it was not very clearly defined whether it included active and passive, whether there was a clear demarcation. Nobody knows. And up to 1 hour in Multip. But they wanted to reduce the number of cesareans. So ACOG included passive and active and brought in 3 hours active second stage for Nalip without epidural, 2 hours for Multip without epidural, 3 plus 1 hour with epidural in Nalip, 2 plus 1 hour with epidural in Multip. Then NICE, FIGO, WHO, they talked mainly about the active second stage. More than 2 hours of active second stage is considered as prolonged, and more than 1 hour of active second stage in Multip is considered as prolonged. So it is important to give time. That is what all these colleges or international bodies are saying. It is mainly, the aim is to reduce the rates of cesarean section, because there are concerns about serious maternal and neonatal morbidity and long-term outcomes. So the definitions themselves are not uniform, and that itself is a pitfall. So let us look at the duration of second stage and how many of them deliver. By an hour, 32% of them deliver. So only 1/3 would have delivered. So if you are intervening within an hour, this is a study in Nalip. So if you are intervening within an hour, then you are going to have only 1/3 delivering. So if you left them up to 2 hours, 60% deliver. This is a spontaneous delivery. More than up to 3 hours, 80%. Up to 4 hours, 91%. So the nature does her job, actually, unless you wanted to intervene for some other reason. So only 9% remain undelivered at the end of 4 hours. So I think it is very important to bear these in mind and give women adequate time. So what happened? Why this cephalopelvic disproportion? Just 1 second. Yeah, causes of prolonged second stage. It could be cephalopelvic disproportion, abnormal fetal position, poor expulsive effort, inadequate uterine contraction, sedation, maternal exhaustion, so many things. So how do we manage the second stage? I think if we want to prevent the delay in second stage, there should be continuous support during labor. The continuous support during labor, birthing companion, it reduces the section rates, as you can see the RR here. Use of non-supine